What are we going to speak about today? One very important thing for a person is identity. That's why we have a name. And that name has a surname. And then we have some kind of a rank attached before or a degree attached after. It tells the other person something about us. So that's why we strive to get an identity. And in today's world, you also bring in your lineage, whose grandchild you are, or which family you belong to. All these things give you identity. And if you don't have those, we call it an identity crisis. And to avoid that, we do so many things to get that identity. We relate ourselves to some distant uncle, auntie, somebody who's become a celebrity and say, oh, you know what? I used to live very close to that person, or I was a neighbor of somebody, or I went to school with somebody. Some way we want to connect ourselves with that. Facebook is full of such things, dropping names, okay? And that way we want to get our identity. But you know what? You can have your identity just being yourself. Just doing some things which give you identity without having to connect yourself with anybody or anything. And that's what we're going to talk to you about today. Hey, I'm going to change the spelling a little. But today's identity is E-Y-E, I-dentity, D-E-N-T-I-T-Y. New dictionary? No. The concept is new. And to discuss this with me, I have my guest today, Dr. Jayashree Bhat.
I'm an ophthalmologist.
Ophthalmologist. Oh my God, why do you doctors have such tongue-twisting names? I don't know. You could have just said, I'm an eye specialist. No, you have to say, I'm an ophthalmologist.
Yeah, that's how we are taught to say, but then I'm happy being an eye specialist.
Yes, not the eye, but EYE specialist.
EYE specialist.
Okay. Jayashree, tell me, before we do talk about the identity concept that you have, tell me a little about your becoming an eye specialist. Where did you study and where do you come from? That times.
I belong to those times when we were told exactly by our parents what to do, and we did exactly that.
But even today they do that, Jayashree.
Is that so?
Yeah, very much.
Times were changing.
It's more so today. It's more so today.
Okay,
yes.
Okay. Now this is something new for me to hear. But then I was told right from the beginning.
And when was this? Just give a fixed time for that. Not your age, but 70s, 80s, 90s, like that.
Yeah. In the 80s.
80s?
In the 80s.
All right.
So, right from the time I was in second standard, third standard, probably from that time itself, it was ingrained into my brains that I should be a doctor.
Okay.
And
do you have doctors in the family, like your parents?
They weren't any doctors. So that's one reason why my dad wanted me to be a doctor.
Okay.
So I said, there's no doctor in my family, so you should go ahead and become one.
Mm-hmm.
And then I was academically good, so it wasn't so very difficult for me to get into medicine.
Mm-hmm.
And I just went on. I got, computer science B seat as well in merit in Bangalore. And then I had to choose between a medical seat and this engineering seat. I chose to do medicine. And then I did my medicine. By that time,
did you develop any, fondness for the thing, or you were just still trying to do that because your parents wanted you to study?
I just was doing what my parents wanted me to do.
Okay.
But then as I went on to do the course, I just saw that I was pretty much adjusting very well into it.
So it wasn't so bad.
I liked studying.
Okay.
I liked meeting people.
Uh-huh.
I liked finding out about how they are and, about their health and stuff.
Uh-huh.
So automatically, I think I just creeped into the right field.
Okay.
But then I never thought I would be a surgeon. I was always having this physician kind of makeup and mindset.
That you'll sit in a place,
that
the patient
I will sit in a
come.
place and then I'll look at a person as a whole. Mm-hmm. I never really thought that I would be diversifying into a very small region like an eye.
Small region? It's the biggest region.
Yeah, it's anatomically very small.
Yeah.
But then I think the way we use it, the importance that it has in our lives.
Oh boy.
I think eyes, that's why it's said Sarvendriyanam Nayanam Pradhanam.
You told us how important it is.
It plays an extremely important role in our lives. So we can just imagine if we just close our eyes for a minute and then try to walk around and do things that we normally do, would we be able to? That just would give us an imagination of how it is like to live without eyes and a good eyesight. Now, for the last 10 years, I was doing typical medical ophthalmology with all the cataracts and the retinas and the
For that, you
diabetic
don't have
eye
to
care.
specialize, is it?
As a general ophthalmologist, we get a hang of all these.
Okay.
Along with that...
No. Let me get this
yes.
right. When you finish your MBBS, or do you do a separate course other than MBBS?
MBBS is one course for the basics where we read every specialty, we graze through every specialty
So
from
you have
top
to do
bottom.
that. You have to do that.
Yes, even ophthalmology is a part of the MBBS.
Correct.
But then we are really not going into depth of that subject.
Okay.
For that, we need to do a post-graduation.
So you're now talking about the PG course.
Yes.
Yeah. Okay.
So my PG course, I did particularly in this ophthalmology for 3 years. In
Why
Bangalore
did you get
itself.
this interest in? Because your parents wanted you to be a doctor, and you became a doctor. Why did you choose this part of the body to specialize in?
This was again not by choice, but by default. I had interest in pediatrics, and that is children's specialty, and I also had interest in ophthalmology. By this time, I was married, and my husband was already an ophthalmologist, planning to start his own hospital.
Okay.
So when I had to choose between these two.
Okay.
I thought a lot. Then we said that no, maybe pediatrics, there would be more of night calls, and it would be very difficult to balance between work and family life. So maybe ophthalmology, where already there is a doctor and I could go and help him out there, and we could adjust our timings, so give more time to the children.
Okay.
So that way probably this would suit better. So then I just went into ophthalmology.
Jayashree, tell me something.
Yes.
Do men think about all this when they choose a PG course?
They don't.
They don't, isn't it?
They don't really have
Why
to.
is it that we women are so large-hearted? Why are we so concerned about everybody except us and think about all this? बड़प्पन है ना हमारी?
बड़प्पन है.
बिल्कुल नहीं.
बहुत ही.
Yeah.
दरिया दिली है.
To think that, okay, because of this, it's not because I'm interested in ophthalmology, but it's because I have to think in future, children's homework, children's exams.
Yes, we have to think of all that.
Yeah.
And that too, I was telling you that I never thought I would fit into a surgeon's role well. This was because I was not particularly fond of obstetrics and gynecology.
Okay.
And during my internship in my MBBS, I had put some very bad sutures after a delivery.
Okay.
So then my gynecologist teacher, she just remarked, "Who's done this job?" And she's like, "You don't even imagine that you will become a surgeon in your life. Hope you don't." So that had gone so deep into my mind.
Instead of teaching you how to do it better, she just dubbed you as really a bad
and then I took it so seriously. I would take everything. I was that very doting and dutiful student. I would take everything very seriously. Then I said, okay, no, I will never even think of becoming a surgeon in my life, ma'am. So I had my own doubts when I joined eye specialty course, because this is mainly a surgical specialty, where we have to be good with our surgeon skills and our surgical hands. Touchwood, I've been having a spotless record last 10 years. And even as a student, like I told you, my husband was already a surgeon. My teachers here would remark, "Oh, you must have already learnt back at home and come, because you're doing it it's not like you're doing it the first time, or you're not like an amateur."
Okay.
So then after some time, whatever she has told me has like gone off.
Rubbed off.
Yeah, has got rubbed off. Maybe if I meet ma'am again, I'll tell her, "No, ma'am, you were wrong."
Okay. So why do teachers have this habit of, just labeling you, or just rubbishing you and saying, no, you can't do it? Isn't it really demotivating for a student?
Very demotivating. But at the same time, I've had some very inspiring teachers.
Of course.
There are different kinds of people everywhere.
But those who do this kind of rubbishing,
yes,
then shouldn't be in teaching profession at all.
Shouldn't be.
Isn't it?
I totally agree.
Okay, so you discovered that you were not so bad.
I was not so bad. In fact, I was good.
Yeah. Let's go that further. Okay, now tell me, this thing about being a surgeon, an eye surgeon, is it even more intricate than being a general surgeon? Different parts of the body. Now you have, for every, like a left finger, you have a surgeon. For a right finger, you have, there's such super specialties.
There's a lot of super specialties around. being an ophthalmic surgeon is definitely not a very easy job, because we have to be good with both our hands. We have to use even the left as well as, so that dexterity is very important.
Okay.
And it is not a naked eye surgery. It is through the microscope.
Oh, okay.
It is a microsurgery.
All right.
So then you have to have that coordination between your eyes, the lenses of the microscope, and then the tissue. And the instruments that we deal with, they are not like real big, huge, bulky instruments. They are all very fine instruments.
Okay.
So the eye, is like so small. And then we deal with the really tiny structures within the eye. So a little bit here and there, it can lead to major, problems in the eye. So we have to be really careful with the way we deal with the tissues. It's a very fine type of surgery. Needs a lot of concentration.
So initially when you started, do you have somebody, like when you learn driving, you'll have a person who knows driving to be next to you. So when you do these kind of surgeries, okay, over the years now, 10 years.
Yes.
But when you did your first eye surgery, did you have somebody to guide you?
Yes, ma'am, we are taught. We are taught so well, and I have been trained by one of the very good surgical institutes, very good PG centers,
Okay.
post-graduation centers. So we are not let to do the entire surgery in one go. We are taught step by step.
Okay.
And initially, we are just taught to do only the simplest of steps. And whenever we have trouble, we are supposed to, call our senior, check with the senior, check with the, helping surgeon who is there. And so we are really taught very slowly, nothing, we can't be aggressive, and we can't play with somebody's health and eyesight.
Yeah, that's such an important, like you say, part of the body. When we are talking about eyes, surgery, what kind of surgery do you for the eyes? What are the kind of ailments? I won't call it an ailment, but what goes for an eye surgery? What are the kinds of things that you have to do?
Just like how the onion is in multiple layers,
Okay.
so even our eye is in multiple layers.
All right.
So what we see on top here may be the most superficial layer, and then there is a middle compartment, and then there is a very much deeper compartment. In short, eye functions like a camera. It has got all these very transparent structures, like the cornea, the black portion of the eye.
Okay.
That's a transparent structure.
Okay.
Then the middle compartment, the most important thing is the lens, which is again a transparent structure. Light passes through all these and then goes and relays on the retina, which is the back portion of the eye. It is like your camera film.
Okay.
So from there, signals go through the optic nerve into the brain. The brain intercepts what we see and then gives us back these, saying that, okay, this is what you're seeing.
And all this takes like nanosecond?
Yes, it's like lightning time, that kind of time.
Okay.
And we do surgeries in different layers. So what I was talking about right now is mainly the cataract surgeries, which is the main.
That's the main number of surgeries you do.
That's the main bulk. Apart from that, there are squint surgeries for crossed eyes.
Yeah. Okay.
The squint surgeries, and then corneal surgeries are there for transplanting. You have heard of eye donation.
Yeah. Okay.
So that eye donation is what we do is the healthy cornea, the black portion of the eye. That is actually kept and saved aside, and that is transposed onto the person who is having an opaque cornea. So that corneal transplantation is one kind of surgery. Then others, you have so many types of retinal surgeries. Now, apart from these surgical procedures, there are so many other non-surgical laser procedures as well.
Yeah, okay.
Now, laser has taken a major role in every part of the body. Even in eye, there are different wavelengths of laser we use for different areas. Like, for example, you must have heard of LASIK, freedom from glasses.
Yes.
So that is a particular laser that we again do for correcting the minus powers and the plus powers that a person has to, wear the glasses. So that is laser surgery. And another, we do lot of lasers for glaucoma. Glaucoma is now just like how we have a blood pressure in the body. There is a particular pressure in the eye which keeps the eyeball intact. That's the intraocular pressure.
Okay.
It can't be too low, it can't be too high. If it is too high, then we call it as glaucoma.
Okay.
Now there are so many laser procedures and surgical procedures to correct glaucoma.
Okay.
And there are lasers again for the back portion that I said, the film of the eye, the retina of the eye.
The retina, okay.
Now, that is again one more domain I do treatment in, that is diabetic eye care. After doing the post-graduation in 3 years for ophthalmology, I went to Arvind Eye Hospital, Madurai, and did my course for diabetic eye care and lasers.
Okay.
So that is again one very alarming thing. I see so many diabetics with very bad retinas, heavy bleeding in the eye, and they wouldn't have ever done an eye checkup because they're not aware of it.
Mm-hmm.
Through Eyedentity, that is one another thing that we are, that's the spirit that we want to educate people. It's just not about treating whoever comes in.
Now tell me how any diabetic has to anyway go and get a retina checkup done.
Absolutely.
And they don't do it.
They don't do it.
It's because of not being aware, or is they don't take it seriously enough?
Not taking seriously enough maybe is the next thing, but not being aware is the first thing. In spite of so much of education, media, and then so many doctors being around. And it's very, very saddening to know that still people do not have that kind of awareness that once there is a sugar detected in the body, that is one of the first things to be done, to get a detailed eye examination by a qualified doctor. What happens is many times this, I think out of 100, 70 to 80% are having the misconception that if you get a computerized eye checkup
that's good enough
done and the power tested, and then you wear good glasses and you're able to see, then everything in the eye is okay.
Okay.
But a computerized eye checkup is nothing but only a computerized power checkup, spectacle checkup. A spectacle checkup by an optician is not equivalent to an eye checkup by a qualified doctor.
And what do they do for that? What kind of checkup is done for the retina thing?
We check the pressure in the eye to look for glaucoma.
Okay.
We either through an undilated pupil, that is, or through a dilated pupil, we have a look at the retina with specialized instruments.
Okay.
That is, it's not possible in an optician setup. Now, there are many people coming to me, diabetics, who didn't know. They said, we've recently checked our eyes. What have you done? Oh, I'm wearing these glasses. I can see well with them. But there would be bleeds in the eye. And diabetic
and there are no symptoms for it?
There are no symptoms. It couldn't be. It could be totally silent and not cause any symptoms at all.
So how often does a diabetic...
is so much on a rise and so alarming.
How often does a diabetic have to get it done?
Ideally, once the sugar is detected, the first eye checkup has to be done.
Correct.
Thereafter, once in a year.
Once a year,
once in a year. If we detect any problem, then we ask them to come more frequently, looking at the extent of the problem and probably how frequently we should monitor. We will probably ask them to come 6 months apart or probably 4 months apart. Or if it is so severe, then immediately treatment would be instituted.
So there is a treatment for that?
There is treatment. There is treatment to cut down the progression. There is no treatment to reverse what has already happened.
Yeah, of course. Jayashree, can you tell us more about this?
Yeah.
Because you say it's on the rise right now.
It's on the rise. India is the diabetic capital and diabetics are so much on the rise.
Why is India so much on? Because
the stress levels and even our genes, we are more susceptible to developing diabetes as when compared to the Westerners.
That's
and earlier it was only in the urbans, and even now even we see that people from the villages also are developing blood sugars.
Do they have stress too?
Probably they are also adopting wrong lifestyles. They are also getting used to the urbanization, and the stress levels must be comparable. So we see more of people from the villages as well who are, who are suffering from diabetes. And
how do you make them aware of it then? How does one make them aware of the fact that they have diabetes? Number one. Second thing
this is something of a question to even me, because in spite of all the exposure that we have, the literature, the media, an urban population themselves are so not aware of what could happen to an eye in diabetes, or whether they have to see the doctor, when to see the doctor, what is it that a doctor can do which probably they won't get elsewhere. So reaching to the village, I don't know, it's so much of a question for myself. It's food for thought, I guess. How do we reach them? How to make them understand? But
I guess there are like Rotary clubs and Lion clubs and all that who have camps. They do have camps. And
what happens during the camps? So we are, this is another dream of Eyedentity. that, I'm having this dream. Usually what we do in camps is we just go, we do mass screening, suggest mass treatment, get them to the base hospital or what, and just give the treatment. Education should be a part and parcel of these camps. That is what we want to plan henceforth. That each time there is a camp happens, the doctor should be able to, give a lecture, and people should be made to listen to that. At least some bit of information goes in. Following that, there should be camps. So it makes more sense. Maybe we are reaching. See, if we are just treating eyes, then we are treating in smaller numbers. But education is
larger.
So on a larger scale. More people, and would be addressing towards prevention of these problems. They can go tell more people.
How about doing this education business even in schools? You can let them know at a very young age.
Yes, in schools also we are doing mass eye screenings. Now our plan, our vision is to go give lectures in schools. Also have probably some interesting activities for children, like painting competitions and essay competitions on eyes, and then give away prizes, and then get the children interested, and after that do a screening, so that then it makes it more complete. So that is the plan we are having. Probably from the coming academic year we will start doing.
You were talking
activities.
about glaucoma, about the pressure, which is like blood pressure, and how common is this?
Glaucoma again is...
and who are the victims of this? Who gets it? Is there any pattern?
Well, again, glaucoma is again a silent killer in the eye. There are not many people who are aware of this.
Okay.
Maybe in the Indian population is about, say, 6 to 7% of the population. People who are having high minus powers and people who are having high plus, both of them are susceptible, but the type of glaucoma in them is different. And even if there is a family history of glaucoma, then it is known to be a very strong reason for it to continue in the next generation.
Oh, it's genetic.
Yes, genetic component is also there. Most of these problems, they are all multifactorial. Genes also plays a role. Along with that, their eye power also plays a role. Plus then, if they have been taking steroids for some reasons, either ocular steroids, instilling steroid drops in the eyes for long term.
Okay.
Or if they are taking steroids in terms of inhalers and all that, if they are asthmatics, then they have a higher chance
So it's a deadly combination if they have that and asthma.
Yes, then there are higher chances that the person has glaucoma. Other than that, if they have some vascular disorder like, a hypertension or a diabetes, or they have any other problem in the eye itself, like, that is some other complication, like if they have had an injury in the eye, then they have a higher chance of developing a glaucoma. And even if they have arthritis, the knee problem, the rheumatoid arthritis and all that, that can also have a secondary, eye problem called as a uveitis, a high reaction in the eye. Now that can also give rise to a type of glaucoma. Now this again, by default, when a person visits a doctor, and we would have looked into all this. There is what is the pressure in the eye, what is the power like, how does the eye look, so how does the optic nerve look. All this without saying, we look into these things, especially if the person is 40 and above. But even then, it becomes our bounden duty that if somebody in the family is detected with a glaucoma, then we have to tell the doctor that there is a family history. So then we look at that person with more suspicion. And even glaucoma, there are drops which have to be administered lifelong. Yes, it is like hypertension or diabetes. Once detected, it has to be kept at bay by using these medications and being on continuous monitoring by the doctor.
This hits any particular age group, or is it apart from being genetic? Does it
usually we see higher incidences 40 and above, but there are congenital, even congenital glaucomas are there. Juvenile, even in the in the adolescent age group also, glaucomas can happen.
And this can also be treated by drops.
It can be treated by drops. There are surgeries also. We weigh for this. It's a customized thing. Like we have to weigh. look at the pressure in the eye, whether it is coming down with medicines, what is the type of glaucoma, whether this needs a laser procedure or surgery or just a topical medication will do, what is the extent of damage in the nerve, whether we could just prolong with drops or whether a surgery would be an immediate necessity. Weighing all this, we take a decision depending on each person.
How advanced are we in India? Because eye surgery is very, very delicate, as you say, very precision oriented. How advanced are we vis-a-vis our expertise and the kind of equipment and everything available?
Proud to be an Indian. We are as good or even better because our population is so much.
Okay.
Our doctors, we are exposed to so many people day in and out. So automatically we have an edge. As surgeons, as clinicians, we see that many number of patients. We definitely have an edge compared to the Westerners. I mean, in cost comparison also, what treatments we are doing here, the same would cost much, much higher abroad. And we are as competent or even better than any other person outside India in managing clinical or surgical challenges in the eye. Equipment wise also, we are definitely having the best of technologies in the equipments. Now there's so much of globalization. We can, whatever machines, whatever lenses are there, they are procured here. They're available locally. So there is no necessity. I don't think there is any necessity for anyone to go abroad to get any treatment. And
okay. I'm not talking about the urban people. I'm talking about, does it reach the grassroots level?
It reaches the grassroots level because eye is one area. Through camps, eye checkups have definitely reached even the masses in the villages. So even they are aware of, they are aware of cataract. They are aware of wearing glasses. But glaucoma and diabetic retinopathy, those areas need to be, educated and addressed more. Because any problem in the eye, people tend, it is either with glasses it gets rectified or it is cataract. Just do a surgery, remove the cataract.
Cataract is only age related, so...
Yeah, mostly. Senile cataract, yeah.
And these days it's not invasive, right? Cataract operation.
It is an invasive surgery.
It is?
It is an invasive surgery.
I thought they do it with laser treatment or something.
No, but the laser, it is actually, we call it as laser. But more than laser, the more time-tested and the in-surgery that is being widely practiced is phacoemulsification. Where ultrasonic energy is used, but in layman terms we call it laser surgery.
Okay.
Earlier the incisions used to be very large. The openings used to be very large and we would close them with sutures and all that. It would take a longer healing period. The sutures would irritate. There would be a lot of downtime, like the person wouldn't be able to really go to work immediately. There would be a lot of watering and irritation. But now the technique that is being practiced widely is phacoemulsification, ultrasound energy being used. And the incision is definitely there, but it is as small as 1.82 millimeters.
Okay.
And through this incision, we go under the microscope, I told you, with the phaco probe. We emulsify the cataract within the eye, dissolve it and suck it out through the same tube and put a foldable or a rollable lens within the eye. So, say probably if we operate on a Thursday, Friday, the person is able to go to work on Monday.
Okay.
Yes.
Even for the grassroots level people, because there are big camps which are being conducted for cataract.
Yes, some of the camps do offer. Some of the camps do offer phaco procedures, and some of the camps are doing the non-phaco but still the sutureless surgeries.
Okay.
Yes, it is. It is.
Tell me a little about Jayashree, if we can make our listeners aware of eye donation.
See, eye donation. It is a beautiful concept. In eye donation, what we need to do is, if a person posthumously wants to donate his eyes, then he has to enroll himself as a donor.
Okay.
Through any one of these places which have provide an eye bank.
Okay.
And once, and then he has to carry his ID card, that I'm a donor, that card with him all the time. And also inform his family members, close kith and kin, that is his wish. So, in case of demise of this person, ideally, between the next 6 to 8 hours,
okay,
the doctors from that the eye bank, they come and they would enucleate those eyes, and then it would be sent to the eye bank, processed, and there is a long waiting list.
It is?
There is a long waiting list.
Okay.
So within no time, these eyes, each cornea, now we would require two corneas two cornea from one person.
Okay.
So each one of them is transplanted. It would give sight to two people.
Okay.
There is some doubts that people have, like, can anybody who is aged donate eyes? I suffer from blood sugar. Can I still donate eyes? I have had a cataract surgery. My eye is already an operated eye. Can I still donate eyes? These are all the common FAQs.
So they can?
Yes, they still can.
Okay.
They can donate their eyes.
Nothing to do with age?
It has nothing to do with age or whether they have had a, previous eye surgery.
Nothing to do with any other physical, like cancer or something like that, if they've had?
Yeah, that has to be informed. Cancer, infective conditions. That has to be informed.
So that means they can't donate if they have cancer or something?
No, in cancer also they can, because we are using only one part, the cornea.
Okay.
The cornea is actually avascular. It has no blood vessels, nothing.
Okay.
So it's as good as a piece of resin. Yeah, it is as good as a piece of resin that is processed and used. It can be, but it is better to inform so that we decide what portion of this eye really has to be put to use. That has to be informed to the doctors.
Okay. When you say what portion of the eye, you mean they take out the whole eye?
The whole eye is taken.
Okay.
The cornea is the one which finds particular use.
Okay.
But even otherwise, there are some procedures where we use the white portion, the sclera.
Okay.
Those scleras are also used as patch grafts for some other conditions.
Okay.
So then there are some other portions of the eye as well which can be used. Main, it's the cornea. So that is the reason it is better to inform the doctors who are collecting about the exact medical condition of the person. What reason? So we take the details as to how the death happened and all that. So, and the eye has to be kept covered once the
person dies.
Yes,
okay.
the eyes have to be kept covered, and a moist cloth has to be placed over the eyes. So that would ensure that we take the best.
I read
corneas.
somewhere that the fan should be on or off or whatever.
The fan should be off.
Yeah, okay.
Yes, because the cornea would dry otherwise.
Dry up, that's why.
Yeah.
And I was asking you, Jayashree, why is there such a long waiting list?
Well,
so many people die.
Yes, so many people die. And if each one of us were to pledge our eyes, then I think within no time that list would, because there are like people being born and
exactly
dying every single day.
It's proportionate.
It's proportionate, but then it's, I think, the lack of awareness, the lack of willingness to do this.
Somebody was telling me the other day, some elderly person was saying, I don't want to donate my eyes because in my next janam, I may be born blind or something like that. So people do have some...
Some people do have some very weird ideas about this. And there are some communities where donation is considered to be very holy. So in these communities, they make it a point that every person whose demise is there, the eyes are donated. It is considered as a good thing to do. So one thing what I would like to tell everybody is that eye donation is not an answer to every problem in the eye. Eye donation, it essentially means corneal donation. So it is an answer to corneal blindness.
Okay.
In case
it's not a solution for glaucoma or anything.
It is not a solution for glaucoma.
No.
It is not a solution if the
retina goes. No, only for the cornea.
Yeah, this is another thing which many people come and ask me that, oh ma'am, has the eye gone off? Can't we just put some donated eyes? So this is another thing that I would like people to know, that corneal blindness, where everything else in the eye is okay,
then only it works.
There is no cataract, the retina is very well working, anatomically it is in place, and the eye is of good structure. From childhood there has been some vision in the eye, and only later on, because of some problem, either an injury or because of some other insult in the eye, the cornea has become opaque. Then the transplantation would work.
What about those who are born blind? Nothing can be done there, is it?
Very sad to say, but born blind means to say that the eye itself is, hypoplastic. It is the sense
Okay.
that it's not developed normally.
Mm-hmm.
Now the eye is like one segment. Like I told you, from the light rays going in, the optic nerve has to be active. The connection to the brain has to be active. Everything has to be working well. So if the optic nerve itself is not developed well, then there is no point giving glasses or doing something in the front portion from the outside.
Okay. So there hasn't been enough research or development in the whole space to find some solution for...
Researchers are on.
Mm-hmm.
It's not that everybody
where you
has
can
just-
keep, like you have heart transplant, liver transplant. Is there an eye
Retinal
transplant?
transplants are also being tried.
Okay.
Gene therapies, stem cell therapies, all these are being tried. But now none of them that I can, vouch and say, yes, this
it
works.
will work.
This
Okay.
works, this is in, and it will work. They are all at still a research level. Nothing is proved as yet.
You're talking about your project called Eyedentity. Tell me about it.
Like I told you, for last 10 years, I was doing conventional ophthalmology. And for the last 3 years, I got this very special interest in human face. So I started attending education programs, conferences, started reading up about, the face. Personally, it started with me that I had a lot of weight loss and then it was all showing on the face. I thought, okay, people would approve of me that I'm all toned up
nice and
looking,
slim.
looking slim, toned up and nice. But then on the reverse, on the contrary, they were asking, oh, you look so weak, you look so tired, you're so haggard. What happened to your face? You look like years older than what you looked last year. It's like you've added 5 years to your face.
Oh my God, how very encouraging.
Then I was like, oh, what is happening? So that got me interested to find out why this happens. Now, some people, we have a selective tendency to lose fat more from the face than from anywhere else.
Or
when
if you
these
put
ones
on,
start-
your face looks puffed up. Yeah.
puffed up. So that's how that was the initial interest point.
Okay.
And then after that, I started exploring into these other, treatments for the face that is being done everywhere around me.
Like what?
Like chemical peels and polishing and...
Polishing your face?
Yes.
Okay, chamak type.
Chamak for the glow.
Okay.
And the party peels.
What's that? You go for a party, you get a peel for that.
There are some
What are we doing to
treatments
ourselves?
called party peels. So I just heard about all this and just try to analyze what's happening around. So then just realize that there is a pressure to look good. And there is earlier it was only probably to one segment of society. It was only meant for the celebrities or the film stars or people in the media.
Socialites and all
Socialites, the page 3. But then now, even when we want to take a receptionist,
we look for the glow.
We do look for some, okay, is she presentable, nice set of teeth, does she smile, does she talk well?
That's fair enough.
It is fair enough.
Yeah.
And that is why everybody has got that need to look good, that pressure to, have nice skin and, everybody wants to look their best.
Yeah. Okay.
Now that is there. That is there in you. That is there in me. That is there in
Even
everybody.
for our own selves.
For our own selves.
Yeah.
Because it is not just about treating diseases and being disease-free anymore. It is about looking good as
Wellness,
well.
what
It
they
is
call it.
wellness. So wellness means looking good, feeling good, looking healthy, feeling healthy, being healthy. So beauty, health, everything goes hand in hand. But then are people getting it in the right proportion from the right people in a scientific way? That is not happening. That is like randomly treatments are being done by anybody and everybody, half trained, not trained,
Beauty parlors
qualified,
especially.
not qualified.
Today you see
Nobody
them
is monitoring
sprouting up,
them.
no?
They're sprouting up like
Everywhere.
mushrooms.
Yeah, and small little chota dukan.
They're mushrooms.
But with huge this thing,
Yes.
come and get yourself.
And then there is no quality check. Who comes and supervises? Where the license is coming from? Who sees the degrees of what these people, what degree do they hold? What is their basis for giving all these treatments? Are they overdoing? Are they doing too less? Are they over-promising, under-delivering? Now, who is there to check? Nobody. So then I said, okay, what's the point in just complaining and, just cribbing about what's happening around? So what can I do about this? So I went to Mumbai in November and did my course in cosmetology and aesthetics from Dr. Jamuna Pai's Institute. Now, she is
She does all the beauty pageants.
Yes, she is the skin expert for the Miss Indias, the Miss Worlds, and the Bollywood stars. So she is the skin expert for them. I did the course under her, and it was a great learning. Once I got back from there, I started this center in Jayanagar called as Eyedentity. Now, my ophthalmology is with me and it will continue to be with me. Now, this is an add-on because that is how we are being recognized. See, neck upwards. Nobody recognizes us by our elbows.
Except when you get tennis elbow.
Except when you get tennis. Maybe, and we all don't have very distinct voice like Amitabh Bachchan's voice to recognize us by the voice. So mainly it is the face and the eyes. That is why if we want somebody to be, not recognized, we put a black strap, screen around the eyes. So the eyes and the face form our identity. So then why don't I give provision to people? The
rest of the body doesn't matter.
The rest of the body does matter, but maximum, I think, this is the man.
If you have a beautiful face, you could look like a punk queen otherwise.
It compensates, to some other areas, inadequacies. It probably can compensate. Whereas the other way, I really don't know.
No, correct.
The other way, no.
You may have a very slim
I told you.
I
tried it, and then when the face was went push down, so it was not a good sight at all. So then...
so what is it that you offer?
Now in Eyedentity, we are a medical and aesthetic center for the eye and the face.
Right.
So that is how I would call it. So it is mainly a medical center. We are treating eye disorders and we are treating the skin disorders. The acne, the pimples, the scars, the pigmentation, the patches. Everything is being treated. I have on board excellent dermatologists, well qualified. See, we have spent years of our lives to study about the human body. They have learnt the skin. I have learnt my eye part. So then we have the right people. We want to give the people who walk into Eyedentity the right solutions, proper realistic expectations, scientific treatments, US FDA approved, time-tested, evidence-based, and nothing random and over-promising. It's not a glorified beauty parlor. We wanted to give everything in a scientific way.
So it's a medical beauty parlor.
You could call that. That's a very interesting. So it is not like not a gray zone where you don't know whether you're you need not be scared to walk into this place. You could very comfortably and very confidently walk into Eyedentity because each and every person who comes in.
So who all do you have here? You have yourself and you have a dermatologist.
I have dermatologist. Then I have a nutritionist on board. Because that is very important.
For
nutrition,
the skin.
For the skin. Diabetic nutrition. She's actually done her majors in diabetic nutrition. So for skin allergies, nutrition is important. To eat the right kind of food is so important because that defines so many things in us. I have a nutritionist on board and talks her on with an ENT doctor as well as a dentist because that would complete the picture.
Dentist is fine, but why an ENT?
Neck upwards. So then that's what I said too. Maybe we are not really trying to give an advanced ENT setup and an advanced dental setup, but then you really have to need not think like if I have some problem neck upwards, where do I go?
So it's one window.
There is a one window. There is one place where you will find these multiple specialities. It's mainly a medical center. Again, I am stressing on this. That is mainly a medical center. We are proper qualified MBBS
Doctors.
plus post-graduation doctors in their specialty. We want to treat people, and aesthetics is an add-on. You want a solution for your medical problem, we have it.
Do you also do repair surgery, nose job, eyes job, and things?
We even have a plastic surgeon on
Plastic
board
surgeon
in
type?
case somebody has really an inquiry. Then that also
That
is
person
possible.
can come. Okay.
Yeah.
Do you recommend it? I mean, is it okay? Like you have all this Botox and all that, trying to look younger. Is it, as a doctor, tell me, is it good for the person who does all this?
It's all individualistic. You could just be happy the way you look.
No, that apart from
Or,
that part of it.
yeah.
If some person finds it necessary in her profession or whatever, like an actress.
Now, Botox is actually being used for medical reasons also. It has got a lot of medical uses.
Okay.
Like, for example, you would be surprised if I tell you that Botox is used to treat migraine attacks.
Really?
Yes.
Okay.
Okay. Now, other than that, it has got its aesthetic uses as well.
Okay.
Botox is, if it were to be so not necessary, it wouldn't have stood the test of time and stayed for so long.
So obviously it
So
has
many,
its uses.
so many treatments they just come and go. But Botox has stayed.
Okay.
Okay, and it is FDA approved treatment.
Okay.
Okay, Botox as
No
well as
side
the
effects?
collagen fillers,
No side effects?
if done by the right person.
That's important.
Yes, because aesthetics is something, it is more than a science, it is an art. How much is less? How
So
much
you
is
don't
more?
have one on board to do that.
I am there.
You do the Botox treatment.
I do the Botox and the fillers. That is why I went to Mumbai. I told you I qualified in that
Okay.
training program.
All right. Jayashree, you've got a very nice thing going for women who want
Yes,
to...
who want
I
it.
would say who want to up their self-esteem.
Who want to up this. And Botox is again not only, anti-aging is one part.
Uh-huh.
It is used even in the youngsters for enhancement.
Okay.
Even the upcoming models, the actresses who are barely in their 20s.
Okay.
Now probably it has picked on too much at Mumbai, Delhi, in these cities. Bangalore always catches up slowly though.
Okay. And is it already launched?
It is, yes.
Your project?
Yes, my project is launched. I think it is
center is
exactly 1 month and 2 days since we launched
The center
it.
is open for
The
consultation?
center is open for
What are the
consultation.
timings?
We are open between 9 to 9.
Okay, and what is the address of it?
And this place is called Eyedentity.
All
Once
right.
again, EYEDENTITY. And we are located in 4th T Block, Jayanagar.
Okay.
So postal address would be number 820, 37th Cross, 18th Main, opposite French Loaf. That's the landmark.
Opposite French Loaf.
Yes.
Okay, that's a good landmark.
That's a landmark.
I do hope there are women who would like this treatment, medical treatment, and not a beauty treatment.
Not a beauty treatment.
So there is place for them to come. Thank you so much, Jayashree, for telling us so much about the eyes, what can or what cannot be done about it, and about identity.